Hello, this is Philip Ross. I'm going to present today left atrium, the A1c of the heart. It is going to be presented as a CME presentation on August 29th, 2012 at NorthBay Healthcare. NorthBay Healthcare is located in Solano County, California, consists of two campuses, one in Vacaville, one in Fairfield. This modern health system provides care for cardiac patients as a STEMI receiving center, for cancer patients, and trauma patients recently as well. Let me start with disclosures. There are no disclosures to be made. What are we going to talk about today? On the agenda, we're going to mention anatomy and embryology of the heart and left atrium. How to measure it? What are the size guidelines given by the American Society of Echocardiography? We are not going to talk about left atrial or right atrial tumors, any significant congenital or intraatrial septal defects. We will talk about size and outcomes. We'll mention also left atrial appendage. And on conclusion, I will try to make point that the size of left atrium is very important. And as a teaser for the next presentation, it's going to be focused on EKG and its relationship to mechanical transport function of the left atria. Let's start with a picture. This is an anatomical picture of the heart. From the front, we can see mostly the right ventricle, partially the left ventricle, aorta on the top, and a gray main pulmonary artery. In the center of the picture, towards the right, is the left atrial appendage. Image from behind shows the left atrium with its four pulmonary veins. Left atrium is strategically located close to the esophagus and therefore allows for the transesophageal echocardiography probe good view into the heart. If you unroof the interior aspects of the heart, you see the relationship of left atrium, mitral valve, subvalvular apparatus, left ventricle, LVOT, aortic valve, and ascending aorta that is open in this case. Looking from behind, again, we see the relationship of main pulmonary artery, left atrium, and pulmonary veins. If we unroof the left atrium, now you see the relationship between mitral valve and foramen ovale on the right side as a slight indentation that can be appreciated. Now this image is reconstruction of the left atrium with its pulmonary veins, and on the left side, the left atrial appendage. Now, if we're talking about a heart, we need to mention at least briefly its embryology. It starts as a single tube with the venous channels on the bottom and arterial trunks on the top. It starts extending, prolonging, and folding over. During the folding over process, the interior structures will give rise of the ventricles, and the posterior structures will be the atria. In this image, you can start appreciating the right ventricle in the front, future left ventricle, and atria above, now on the right side the left, and future right atrium on the left side. This image shows the development of intraatrial septum, the septum primum, that closes on the left side almost completely, leaves the ostium primum there. Then in a short time, ostium secundum will generate and the ostium primum closes. Septum secundum starts growing over and mostly closes the foramen ovale that has just been generated. On the right side, the interventricular septum will conclude its generation by complex process of dividing the trunks into main pulmonary artery and aorta. This image is the basic four-chamber view obtained from the transesophageal mid-esophageal views. The TE image always has the left atrium on the top as the most posterior structure. Mitral valve is well demarked here, followed by left ventricle in the center of the image, and right-sided structures on our left side. This image shows a moving 4-chamber view with a little LVOT aortic valve in it. I want you to focus on the motion of the mitral annulus. During systole it descends, and during diastole it recoils upward. Apex again during systole is stationary. Now this can be proven on a tissue Doppler imaging, as is shown here, where you put a pulse wave Doppler and the lateral mitral valve annulus. And during systole, following the QRS, the green QRS, you can see a negative deflection S wave, as the annulus is descending towards the apex. At the conclusion of systole, early diastole starts with the tissue moving upward, as depicts on the E prime positive deflection. That is the early diastole, passive filling of the left ventricle. Then the ventricle takes a little break, and followed by the atrial kick, the A prime in this case, where the mitral valve annulus continues upward motion towards the transducer, caused by the atrial contraction. This mechanical motion will explain some of the flow and pressure changes that we will see in the left atrium. This is an image of cardiac cycle with, on the bottom, in a light brown, we see a left ventricular volume as it rapidly declines during systole and slowly increases during diastole. Now in the middle of the image, in light brown, we can see the left atrial pressure tracing that starts with the late diastole and atrial contraction, where the pressure increases. Mitral valve is still open, the left atrial pressure decreases, and now mitral valve closes, early part of the systole. Pressure in the left atrium rapidly declines during systole, early part of the systole, and this is caused by the mitral valve annular motion towards the apex during systole, deforming the left atrium and causing a decrease in the pressure of the left atrium. As the left atrium slowly recovers by filling, pressure rises and then drops at the early diastole again after mitral valve opens during the passive ventricular filling. Now here we have 2 QRS cycles and we have diastole in the center. Again, this is now focused on a flow patterns across the mitral valve, shows an E wave as the early diastolic filling, an A wave as the late diastolic filling, and its relationship to the left atrial pressures. And again, during the atrial kick, as the left atrial pressure rises, that is when we appreciate the increase in flow across the mitral valve for a left ventricular filling. This is the actual trace. In this case, we're putting a pulse wave Doppler at the tips of the mitral valve annulus, but you can use a continuous wave Doppler and you can put the pulse wave Doppler anywhere you desire, and it'll show the same pattern with varying velocities. The E velocity is the early filling, and A velocity, following the P wave on the QRS, is the late diastole and late diastolic filling. On the other hand, if we sample flow patterns in the pulmonary veins, we see a quite different pattern. Following the QRS in a systole, S wave is a positive deflection, meaning flow increase towards the transducer into the left atrium from pulmonary veins. This is caused, again, by the deformation of the left atria by systolic motion of the mitral annulus towards the apex. As the annulus descends, deforms the left atrium, creates negative pressure or significantly decreased pressure in the left atrium, and that promotes the flow from a pulmonary vein into the left atrium. That's what the S wave is. Now, early diastole, mitral valve opens, and a passive filling starts. That is followed by another increase of flow from the pulmonary venous circulation into the left atrium, displayed here as the D wave, positive inflection. That, however, is followed by negative wave, A wave, that is an atrial contraction, that late diastole, the atrial kick, and is negative because as the atrium contracts and expels the blood across the mitral valve, it also pushes the blood back into the pulmonary venous system, and that's why we detect the negative flow for a short period of time. Size matters. Now let's talk about that. How do you measure left atrium? The easiest and most reliable way is by echocardiogram, transthoracic echocardiogram. There are different ways to measure it. Here in this, it depicts a couple different methods, area length, measuring dimensions, but at the end of the day, the most reliable, the recommended way is method of disc derived from 4-chamber followed by the 2-chamber views, where Simpson method of disc will calculate closely the actual volume of left atria. Here on the left side, see a tracing in the 4-chamber, and then on the right side, you can see tracing into the 2-chamber. The best thing with this measurement is to index it. Once we index the left atrial volume based on body surface area, as highlighted in this data on the bottom, you can see that a normal range for men and women is identical, and is 22 plus minus 6 milliliters per meter square. And above 40 is severely enlarged. Now let's see if it does matter, if the size does truly matter. In this study from 2011, 36,000 patients were followed with a preserved systolic function, and their survival was monitored. And if you look at their left atrial size, index size, volume, followed by a period of 40 months, there was a dramatic decrease in survival in patients with an enlarged left atria, in patients with preserved systolic function. Even a mild increase in size showed as a decrease in survival estimates. This is a different study from 2011 that measured left atria slightly differently, but again, over the period of 15 years, showed a significant decrease in survival based on the left atrial diameter. Now, what about cardiovascular events and left atrial size? Now, cardiovascular events in this study from 2007 were defined as cardiac death or non-fatal myocardial infarctions. And here again, they measured left atrium, indexed it, but it was a different way of measuring. It was a short size, and the cutoff for normal was 2.5. And you can see there's a significant rise in event rate from 2.5 and above. So clearly correlation between the left atrial size and incidence of myocardial infarction that end up being fatal. Non-fatal myocardial infarctions or cardiac death. Now, if you look at the survival free of stroke in the same study, from a 2011 study, you can see again significant increase in stroke rates related to an increase in left atrial diameter. What about relationship of left atrial size and stress echocardiograms? In this study, the objective was to really look at diastolic function as measured by the left atrial size, and we will mention that briefly, in patients that were undergoing stress echocardiography studies. And the conclusion was that the left atrial size provided independent and incremental value in assessing as being a powerful prognosticator and should routinely be used in prognostic interpretation of stress echocardiography. And I'll show you the data. Now, in this study, they also looked at cumulative survival, in this case in a normal stress echo patients divided by increased left atrial size or dilated left atrium, a normal left atrium. And if you see the dilated left atrium translated into significant survival decrease. If you add the stress echo study results, you can see that dilated left atria in an abnormal stress echocardiography patient had a strongly associated decrease in survival compared to a normal LA with a normal stress echo. As we said before, even the normal stress echo patients with dilated left atrium had a decrease in survival. Now, if you look at incremental prognostic value of varying parameters, and you start with a clinical, you add a stress EKG, you add a resting echocardiogram, you add a stress echo, and you continuously increase the prognostic value. If you continue to add the left atrial index size, you still increase the prognostic value. Now, on the other hand, this study looked at it slightly differently. Here, they took normal left atrial volume patients and look what happens with stress echocardiography results in these patients. And the conclusion was that if you have a normal resting left atrial indexed volume, it is strongly predictive of a normal stress echocardiogram. Therefore, left atrial volume indexed might be a simple means of identifying patients with low ischemic risk and should be further evaluated as a complement to the assessment of ischemic risks. Meaning, if you have a normal left atrium, you're highly likely to have a normal stress echocardiogram and a low ischemic risk. What about diastolic function and left atrial size? You can probably spend a whole week of conference and presentation about left atrium, left atrial size, and diastolic dysfunction. But we will narrow it down to really only 2 slides. You cannot have diastolic dysfunction without left atrial enlargement. If you look at varying parameters and try to assess severity grade of diastolic dysfunction and you include ejection fraction, you can see that on the right-hand side, the grade, being 1 to 4, is scattered. But if you sort the data based on left atrial size, it becomes highly correlated with the grade, meaning highest size left atria will have the most likely higher grades of diastolic dysfunction. And as you can see here, you can have a significant diastolic dysfunction in scenario of preserving left ventricular systolic function, as we know. What about left atrial appendage? Now, left atrial appendage, there is probably strong association between something called an emptying velocity and strokes, and I'll show you what that means. Now, left atrial appendage area seem to be correlated with the incidence and frequency of atrial fibrillation, but not to stroke incidence. Now, this is an image of a normal left atrial appendage on the right-hand side, nicely contracting, unilobar, and no echocontours, no clots. This is, on the other hand, enlarged left atrial appendage in a very enlarged left atrium from an X-plane imaging from a TEE. No clots, no echocontrast, but probably low emptying velocity. Now, what's an emptying velocity? It is a pulse wave Doppler derived flow pattern from the left atrial appendage. As the blood during contraction of the atria leaves the left atrial appendage, we measure its velocity. And you can see a good example here. Following the P wave on a QRS, strong positive wave is recorded. Measured, and in this case is probably close to 60 centimeters per second. That is a nice, good, strong atrial emptying, left atrial appendage emptying velocity. On the other hand, this left atrial appendage emptying velocity is measured at 22 centimeters per second, well below the cutoff of 25 centimeters per second, considered to be a low end of the normal. This will give you a semi-objective measure of a thrombogenic propensity on the left atrial appendage side. Now, what's a spontaneous echocontrast? Low flow state that you can see here in the left atrium that is enlarged, as well as the left atrial appendage. Again, a low flow state, probably propensity to higher for clot formation. Now, left atrial appendage here visualized by three-dimensional echocardiogram. You can see beautifully inside. You can differentiate clots from trabeculations. You can see a multilobar left atrial appendices. Now here, in this case, we unroofed the left atrial appendage digitally, and we're looking inside and can appreciate the heavy trabeculation of this unilobar left atrial appendage. On this image, we see the relationship of mitral valve in the center, left atrial appendage on the left side, aortic valve on the top side, as we call it a surgical view, where anterior leaflet is on top, related to the LVOT, and a posterior leaflet is on the bottom. And again, left atrial appendage is to the left. Now, what we are not sure about left atrial size? Well, left atrial enlargement represents a risk marker or a stroke risk factor. We're not sure. We're not sure if interventions aimed specifically at reducing LA size might be a viable preventive interventions, and we'll need to have more studies on that. Now, several studies reported a novel association between the LA enlargement and strokes, but interestingly enough, there is no consistency between men and women. So, for a conclusion, left atrial size is very important. Left atrium and its size functions as a long-term A1c of the heart and body, and shows us the well-being. Its enlargement highly correlates with mortality. It also correlates with strokes. Indexed volume by method of disc from forward and two chamber, the Simpson method of disc, it is the most reliable measure, and it's recommended by the American Society of Echocardiography. It is very easily obtainable with a transthoracic echocardiogram, and a transesophageal echocardiogram is probably the gold standard for assessment of either a function of the left atrium, as well as the assessment of clots and left atrial appendage assessment. Now, please do look for it on the echo reports. We need to look not only at the LV systolic function, the diastolic function, the aortic and mitral valve functions, the right ventricular function, systolic, but the left atrial size is, especially presented in an indexed volume, will give you a very strong predictive value for your patients. And the teaser, as we said before, next time we'll spend some time discussing the relationship between sinus rhythm on EKG and the mechanical transport function of the left atria after ablations of MACE procedures. Does EKG suffice for assessing function of the left atria or not? And this concludes this presentation. Thank you very much for your attention.